Thanks, Terry. So it's my pleasure to be here merely as the spokesperson for hundreds of people that are involved in the project and hundreds of thousands of veterans that we view as our partners. And here in the room are the people who are going to answer the tough questions. Dr. Tim O'Leary, who conceived of the scheme, and with him are Ron Puzgotsky and Suma Muralidar. So it's an exciting time, and with the presidential win behind ourselves, I think the biggest mistake we could make would be not being bold enough. So we're attempting to address this massive signal noise problem, and it's I think, a very exciting time. What I'm going to share with you is a 10,000 view of how we addressed this in a mega cohort, what I think of as the fourth phase of epidemiology. The first guy to use big data was our great-grandfather of epidemiology named John Grant, who used death and birth records in London to create an actuarial methodology. So we're circling back. We've gone through the case-focused methodologies in the 19th and early 20th century with case control styles. And then the third phase was multivariate modeling, computer technology, that we've heard a lot about today at Framingham. Now we're in that era of using these new enabling technologies that Dr. Kahn's talked about, massive health data and other social types of data, omic data, and computing power. And what we've done is we've created a platform, much like has been talked about this morning, nested in the VA healthcare system, which is an ideal setting for population research because we have these stable, willing, and committed veterans who are durable in the program. Dr. O'Leary engaged in an opinion survey to see what they thought about it, and we geared our program toward those sentiments. We have an outstanding electronic medical record. We have CMS and NDI data that comes to the VA for our participants, and we have a research infrastructure that we had to build over the last decade to get to the point where we are. And then we've got a couple of prototypes of how we're nesting data within the system. We've got a pragmatic trial that doesn't use sites. It contacts people directly and then uses the healthcare system to deliver the intervention and track the experience, and then the Million Veteran Program. Now, what we did was the same thing that we're doing today. Is my then deputy Liz Lauder created a database of similar activities going on, and what we did was relied on the wisdom of a number of people that are in this room, including Dan Roden at BioView and Neil Reish at Kaiser and Rory at the UK Biobank. Visited Decode and looked at their biobank and used that wisdom to figure out what would work given our own constraints. And so what we came up with is the cohort to enroll 1 million, perhaps go beyond that if we can, collect individual data that's not available in the record, a biospecimen, access the medical record forward and backward in time, and then have an ability to recontact participants. And we used the existing infrastructure. I think there's only 1 or 2 boxes on this whole thing that are relatively new, like the MVP Executive Committee. But we reorganized and created links between existing infrastructure. This is a bit outdated. It's gotten a little bit more complicated than this, but the general idea was to use existing infrastructure that we have and organize it toward a massive effort. So how do we get our participants in? Well, given some restraints with our ability to use electronic means of communication, we use an old school technique, but still quite effective, where we send out invitational mailings, and they send back questionnaires. We send them appointments. They come into their study site, and that study site visit can be a 15 or 20-minute experience. We get a consent and HIPAA signed, collect a blood specimen. Then we send them a thank you letter and a lifestyle questionnaire. And then specimens are sent centrally. We had to create some robotics. We learned a lot from the UK Biobank on the robotics of processing. We processed 400 to 600 a day. We had a record post a very long snowstorm delay of 1,400 in a single day a couple of weeks ago. They are stored in a space-age biorepository with a robot operating down the center. We recruit at 50 sites around the country. We've decommissioned 5 centers and brought on 5 new ones. And here's where we are today. 2.9 million mailings went out. We get about a third of the people respond back one way or the other, most favorably. We have about, as of 10:50 this morning, we had 348,532, which I rounded to 349. And most of those provide adequate specimens into the lab. We are doing send out of the specimens for whole genome sequencing to the tune of about 2,000, 25,000 for exome sequencing, done by two technologies, an Illumina platform and an Ion Torrent platform. And we are lots of duplication. The 25,000 are about half African Americans. So it's one of the larger sequencing endeavors in African Americans. And then we've done genotyping in 200,000, and we're slated to do another 200,000 this year. We used a platform that after talking to Dan, Neil, and Rory, a very similar platform, but we added VA custom content to an existing platform, and this did two things. One is it geared toward our population to answer some specific questions, but we also helped create the community of investigators that feel some investment in this process. Now I want to turn our attention to the challenge of dealing with data in a single healthcare system. So we define the data universe as molecular data, self-reported data, data that we have ready access to within the VA, and then non-VA data, such as NDI, CMS, state mortality data, et cetera. And we have the ability to link. We have Social Security numbers, and linking is easy, but curating is the challenge. So we have the domains of data, the lifestyle and baseline surveys. This is a longer questionnaire. We have depression scale, a food frequency questionnaire, good smoking history, self-reported race data. Then we have our genomic data. Then we have the VA health system data and these other national data sources. So I want to speak a moment about using the VA health system data, which is a real challenge. It's not one file. The nice thing about the VA data is that it's horizontally integrated, meaning we have primary care data, we have medicine data, we have enormous lab data. I can go back for 20 years in some cases. On some patients, I have 20 years of creatinine. But there are enormous challenges with using this data, with curating it, even within a single health system. Anybody have any idea how many variables are in our lab file that have the word albumin in it? There are 3,000. Yes, 3,000. Another example, when we're curating something like as simple as Alzheimer's disease, which was mentioned earlier this morning, different doctors use the terms, the same ICD code differently. And through a careful validation process, we learned that primary care docs and geriatricians and neurologists use that code very differently. The neurologists and geriatricians, when they say Alzheimer's, they mean Alzheimer's. When a general practitioner uses that same ICD code, they mean generic dementia. And so not having that metadata makes your phenotype not quite as accurate. So there's enormous challenges. Our data is organized in patient system data. We also have benefit data that we can bring into this, and then we have special registries that exist within the VA, disease-specific registries, a diabetes registry, an HIV registry, all of which are accessible, but one interesting challenge is they all have slightly different rules of engagement on how you can repurpose the data. This is set up as a repository, which allows us to repurpose much of the data, but it's enormously challenging in a single health system to be able to organize the data in a structured way. Now, this is a schematic of how we're trying to organize the data, and the general philosophy is do not boil the universe. It's we bring in the data, but then we clean selective parts, and I'll show you in the next slide what we're cleaning. We bring it in to the landing zone, then we move it across to the workspace with these sandboxes. There will be broad access by lots of investigators, but they will come to the environment, bring their tools to the environment, query the data with metadata, and then have their study data sets put up in accordance with the specifications. So we're working on about a couple hundred variables in first-tier cleaning, and then some complex disease phenotypes, developing simple algorithms. And here's our philosophy. We have a 3-tier approach. We develop a tier 1 intuitive algorithm. Then we let the clinicians extract data from the records and perhaps inform us of other data elements that might be helpful. We may need natural language processing. We rarely use natural language processing at this level. We end up with a 3rd tier that we further validate. And if we further validate it, we can do something that's antithetical to the clinician's view of the world, which is we can assign a probability of caseness to a particular individual. And that allows us to use rather than just saying yes, no. So if an investigator walks in and says, I need 500 cases, I need perfect 100% certainty of Alzheimer's disease, we'll tell them we can have 500 cases. But if you take 98% certainty, we'll give you 10,000. And that number can move. So it's a probabilistic approach to thinking about phenotype. It's all done under the auspices of an ever growing computing environment. Genesis is the acronym for the database, working very closely with another entity that is a purveyor of data called Vinci. We have R&E applications, data storage, a reporting environment that gave me that number today, our LIMS system, and then the scientific environment. So just to finish up, we've got projects underway, and these are the people that I would like to acknowledge in fine print that are contributing to the effort. And my last message is to not let the perfect be the enemy of the good. We are in many ways building it as we go. Thank you, Terry.
Thank you, Mike. Any clarifying questions for Mike? Pearl, and then
there it is. Just one question regarding consent. Are people reconsented over time and reminded they're in a study, or is it just up at the beginning?
So they give broad consent at the beginning, and they are reminded of their participation through periodic newsletters. And we have a website that we will continue to update. But they're not reconsented, and they're not asked periodically, do they want to participate? It's a very broad general consent in the traditional sense.
and I have
Kevin,
and I
Patrick,
think,
if I understood correctly, you're doing self-report for the lifestyle issues. Is that correct?
So we have self-report data. But what's nice is there's an interplay between the EHR. We have some data. For instance, take smoking. We have smoking variables that we've cleaned, and we're in the process now of comparing self-reported smoking data. So it's going to enhance our understanding of what we have in the database. But in many cases, there's no real dietary information.
Are there plans to move to mobile technologies, as we spoke about earlier?
So the nice thing is that this is a customizable platform, and we have a patient portal as well. So the capability is there to move in whatever direction.
One last question? Yes.
Mike, it's very nice. I just wonder if you can help us understand how you reconcile what I think has been the central tension that has been introduced as we've discussed these issues, which is this issue of heterogeneity, fidelity of the thing. So you're basically creating this big platform, but you must have had to deal with this question of, what are you doing? Like, what are you doing it for? And what's the purpose in the end going to be? Because you're going to have this wonderful platform, but I think, for example, you could spend a lot of time refining the smoking variable, but maybe that's not that important. Directionally, it's correct enough. And to know what's worth investing deeply in and what's not depends on what you're actually going to do with it. And I'm just saying what I've heard so far today is this tension between the idea of build this amazing platform and it'll be available and they'll come and they'll use it versus
and I think that's akin to Seg's question. So what we are trying to create a pluripotent platform that can go in many different directions. We won't be able to answer every question. We have a handful of prototypical questions that could be asked, but the capability could be enhanced. Now, we do adopt a strategy when it comes to cleaning and curation, is that we don't deep tier phenotyping and deep tier cleaning that may include validation, recontact, until an investigator is really interested in that variable. On the other hand, there's certain demographic variables that we are going to invest in, age and gender and race and things like that we think are going to be used over and over again. But that's the general philosophy, is we're trying to build something that is usable to many.
Do you have an idea what your first home run project is?
We're going to follow up the other questions later on. We will have a discussion section, but we just wanted to get the clarifying ones first. Mike will happily give up his lunch session to answer those questions. And our last speaker is Eric Borwinkle from the University of Texas, who will talk about building a consortium.